And good morning, everyone. I'm pleased to be here, and this morning, what I'm here to talk about is what we can learn from one of the health service and policy research initiatives that Alba made mention of, the Cadre program. And now, given the fulsome background that Alba did provide, I'll spare you from the detail on that background. However, I will underscore that the Cadre program was created to address the critical shortage of research capacity in the field, as Alba mentioned, emphasized as well. And all of the Cadre components, including the chairs, the RTCs, the PDAs, they were all linked to the key conceptual framework around linkage exchange and knowledge transfer, a model which drove CHSRF for the past 15 years. Now, one of the critical shortcomings of many research programs and policy instruments and so many other aspects is that often there's no built-in evaluation mechanism to answer that most basic question. Well, sorry, Steve. To answer that most basic question, did the program achieve its goal? The Cadre program was designed to include an evaluation component. Over the 12-year lifetime, from 2000 to 2012, it was the subject of formative evaluations, as well as several studies and analysis of its processes and its results. In 2010, CHSRF and CIHR commissioned an external evaluation of the Cadre program as a whole. The focus on the evaluation was to better understand the outcomes and contribution of the Cadre program to building awareness and use of research evidence by decision makers, to shifting the research agenda, and to developing and sustaining a culture of linkage and exchange, the capacity legacy, as it were. Now, given we're just finishing up final analysis of the Cadre evaluation piece, what I'm going to talk about today is findings that have emerged from the case studies that were conducted. I'd also like to flag some of the limitations of the program as revealed by the evaluations and considerations that do arise from it. Now, first, a little bit more about how the case study component of the evaluation was carried out. The evaluators conducted 19 cases to explore how a range of health system organizations engage with applied health services research and nursing programs. And more specifically, they aimed to provide a qualitative understanding of how Cadre developed relationships with health system decision makers and the impact of those relationships. The organizations studied were a mixture of provincial ministries or agencies, regional health authorities, federal departments, district health agencies, teaching hospitals, quite a variety. These selected cases included both nominated exemplar and representative examples, and a total of 54 interviews were conducted with a combination of Cadre trainee and awardees, key informants from the decision-making organizations, and in some cases, university representatives. The interviews were then supplemented by document reviews of the annual reports of the RTCs and a Cadre vitae that was developed as well. Now let me turn to the three areas where the evaluation, or specifically the case studies of the Cadre, has demonstrated some results. Let's look first at the impact of Cadre on awareness and use of research evidence by decision makers. The case studies are finding a number of examples where Cadre has contributed to the production and use of research, as Alba was mentioning, in knowledge in health systems at all levels, and more importantly, to a sustainable increase in capacity to do so. Let me give you some concrete examples of this. In one case, the health district level, Cadre-supported work led to a new organization-wide related policy that has now begun to influence policies in other districts as well. In other cases, Cadre contributed to organizations' capacities for evaluation, both formal commitments to evaluation and a culture of making better use of available data to understand and improve performance. One organization reported that its relationships with Cadre resulted in the development of tools and the conduct of evaluations that would not have occurred without this major support from a university-based research unit. Cadre also resulted in increased capacity among organizations to understand how policy change occurs and how to influence it. For example, one organization that had been resistant to a policy that a Cadre trainee had developed became more comfortable with it following a stakeholder involvement process that was learned through Cadre. Finally, the cases also suggest that Cadre contributed to stronger connections between research evidence and decision-making. Another example, one organization has adapted the use of evidence as a core value within its principal statements. Improving the quality of decisions through the application of evidence is now seen as a part of the overall organizational strategy. Another of the areas that evaluation looked at was shifts in research agendas. It found that Cadre generally, but not always, maintained or increased capacity to co-construct research agendas with decision-making partners. Let me give you some examples that have emerged from the case studies on this one. Cadre explicitly linked research and policy. One organization and a Cadre trainee had worked together on expanded research questions to better align them with the organization's interests. Involvement in Cadre had impacts on research agendas beyond the specific projects conducted. For example, one trainee noted that as a result of her Cadre involvement, she now takes policy questions into consideration when developing research questions, methodologies, and analysis within her organizational practices. Finally, Cadre involvement permitted organizations to adapt and evolve their research agendas. One organization faced resistance from its external partners to its evaluation approach. The Cadre trainee assisted the organization in adapting its approach, which had been highlighted and highly process-based, to focus more on the outcomes. Turning now to the development of a sustained culture of linkage and exchange, there's some evidence that Cadre has left a legacy or capacity to apply research evidence in partner organizations. One organization reported that more clinicians are asking for evidence-based help in their units, and there is less of a fight to secure resources for this, making it easier to build research and evaluation capacity. There was also evidence that sustainable networks developed among Cadre participants and collaborators existed. For example, in one case, the Cadre trainee worked with its decision-making partners to gain access to and partner with high-level healthcare reform think tanks. The case studies also found examples where trainees who graduated through Cadre have gone on to take on roles of mentoring, supervising, and hiring the next generation of applied health services and nursing researchers. Finally, there were many case examples of partner organizations now staffing internal research positions and creating forms of research infrastructure. In the future, funding opportunities might consider how to support the growth of research capacity outside of universities. Overall, the case studies taken together illustrate examples of the legacy Cadre has left in terms of capacity to help policymakers address their needs. The program has equipped participants, particularly trainees, with a comprehensive understanding of health system issues and problems that are highly appreciated by decision makers who grapple with complex challenges on an ongoing basis. So overall, those are some of the successes that are emerging from the Cadre evaluation. Contributing to the use of research by decision makers, shifting research agendas, and building sustained culture and capacity for linkage and exchange. But there are some caveats too, and I'd like to spend my last few minutes talking about those. The results of the case studies, not surprisingly, were not uniform. In some cases, Cadre did not succeed in embedding an evidence-informed organizational culture of linkage and exchange, suggesting that there is room for further development and improvement. In other cases, organizations noted incapacity or unwillingness of researchers at times to negotiate a research agenda. There are also challenges for the Cadre researchers in working within the hierarchical structure of health system organizations. One researcher, for example, there were researchers who were used to making decisions and acting on them without having to work through several layers of bureaucracy. Other problems identified were external to Cadre and its partner organizations. For instance, academic reward systems, which often fail to adequately recognize and reward the partnership element of initiatives like Cadre. One shortcoming of the program was that in many cases, Cadre research partnerships were not new relationships, but existing partnerships, capitalizing on new opportunities to strengthen or expand them. These relationships would likely have continued to develop in the absence of Cadre, although Cadre may have accelerated or deepened the collaboration. Now, overall, in conclusion, high-quality training and mentoring programs are essential to the development of a robust community capable of addressing today's and tomorrow's health system challenges. The case study component of the Cadre evaluation and its 12-year investment points to the impact such a program can have and provides lessons for moving forward. In the coming months, CHSRF and CIHR will be releasing a full summative report of the Cadre program, which will provide a fulsome account of both the outcomes and the findings. I hope that you all stay tuned. Thank you.